Hello, everyone. Good afternoon. I am Dr. Terry Murray, President of the Friends of the National Institute of Nursing Research and Professor and Dean Emerita at St. Louis University School of Nursing. I am delighted to welcome you to our FNINR listening session. Next slide, please. So we are just a little bit about us. We are the Friends of the National Institute of Nursing Research, an independent nonprofit organization. We were founded in 1993. Nurse researchers are grounded in clinical nursing practice, as you know, and focus on the physical, mental, emotional, and social needs of patients, and I'm going to add families and communities. We recognize the illness and the presence of health risk factors affecting the overall well-being of individuals. So with that said, I'm going to give you a little bit of background about our strategic planning context for this meeting. Today's session is a stakeholder engagement session. It is designed to gather as many perspectives as possible in a structured way to inform NINR's next strategic plan. We are joined by the FNINR board members who will serve as panelists and respond to key questions live. During this session, all attendees are encouraged to actively participate by sharing their perspectives in the Q&A feature. Your input is a critical part of the session. We will review it in real time to identify key themes and insights. If time allows, facilitators may uplift and highlight themes or representative comments from the Q&A to ensure your voices are heard and reflected in this discussion. So, thank you again for being here and contributing your expertise and experience to this collaborative effort. It is a stakeholder engagement listening session. So to ensure that we hear from as many of you as possible, please share your responses throughout the session using the Q&A feature. All information in the Q&A feature will be shared with NINR. Keep comments concise, forward-looking, and centered on opportunities and future priorities. Phrases are perfect. Build on the ideas from panelists whenever you see that there is alignment. This particular format allows us to capture broad input while maintaining a very focused discussion. So next, what we're going to do, we would like to understand who is attending today. So please respond to the poll that we will push forward. And remember, the poll is completely voluntary. And we'll give you a minute or so to do that. So I believe that information is coming in. We're at about 50%, 70%. And that looks like we're holding at 70%. So, no good, we're getting 80%. The poll is voluntary, but if we could get 100%, that'd be great. So I would say 71% of you are researchers. We don't show any clinicians, about 8% educators, health system administrators, 7%, community public health partners, none, early career scientist trainees, 3%, and others about 10%. So we are moving on to which setting best represents your work. We have 71% academic institutions, 9% health system clinical settings, no community-based organizations, government about 14%, 2% industry, and 4% other. What is your career stage? We have 6% trainees, 29% early career, 41% senior scientists, and 8% executives. So very good. Now that we know who's in our audience, we will move to the next slide. And I am going to introduce to you Dr. Aklin, and she's going to provide the overview of NINR and the context for today's listening session. I would like to invite our FNINR board members and panelists. They're going to be introduced a little bit later, and each of them will take turns responding to your responses. So without further ado, I hand you over to Dr. Aklin.
Thank you so much, Dr. Murray, and thank you all for being here and for the work each of you are doing to advance nursing science. And just a immense thank you to FNINR and our panelists for hosting today's session. I want to take a few minutes to ground us in how NINR is positioned within NIH and HHS and how we're thinking about our role specifically within that context. Then we'll move quickly into the discussion because the session today really is about informing where we are going to go next. Next slide, please. At the highest level, I want to point out that our work sits within HHS's mission to improve health and well-being and to advance the underlying science. That dual emphasis of services and science is important, though, as it reinforces our role is larger than just generating knowledge. It's also to ensure that it's relevant to how health is actually experienced and delivered. Next slide, please. HHS is a large and very diverse ecosystem spanning public health, financing, regulation, services delivery, and many other sectors. NIH plays the research role within this grouping, but nursing and nursing science operate across many of these divisions, so I wanted to make sure to point that out. For example, within the CDC, the Centers for Disease Control and Prevention, nurses are central to population health surveillance, prevention, implementation of public health interventions. Within CMS, we have nursing informs the care delivery models, quality measurement and improvement, and payment-linked outcomes. Within HRSA, there's a strong focus on workforce development and care access, particularly in underserved areas. Within the Food and Drug Administration, nursing contributes to the clinical trial implementation and real-world evidence generation. But across all of these systems, nurses are often the interface between the individuals, the care systems, and the communities. So when we talk about nursing science at NIH, we're contributing to a much broader landscape of activity across all of HHS. Next slide, please. You're all familiar with NIH's roles across the research continuum, so I'm not going to spend a lot of time speaking to that. But what's important for the purposes of today is the expectation that the institutes contribute to a balanced portfolio from discovery through application. So for NINR, our comparative strength and the responsibility that we have is in ensuring that the discoveries translate into meaningful health impact in real-world settings. Let's stay on this a little bit longer, Justin. Our mission for NIH is obviously to emphasize both the understanding of systems, but also applying that knowledge. The application piece is where we are particularly situated, not in isolation, but as part of the broader scientific enterprise. Next slide, please. And specifically for NINR, the role is to lead nursing science to address the pressing health challenges that inform both practice and policy. We are not defined by a disease category, which gives us the flexibility to define the problems we solve and the context in which they occur. This includes a strong emphasis on optimizing health across populations and various settings. Next slide, please. But what differentiates NINR is our focus on how health happens. That includes the interaction of individuals, environments, systems, and behavior over time. That positions us to address the questions that are often undeveloped elsewhere. So specifically, it allows us to examine the questions of what works, for whom, and under what conditions. That gives us the ability to then translate what we're finding into practice and systematic changes. Next slide, please. So from our perspective, the role of NINR is to form a portfolio perspective, one that is roughly $190 million annually in research. But that includes extramural findings from across the country, as well as our intramural work here at NIH. We are intentional about supporting research that is pragmatic, implementation oriented, and designed for uptake and scale. And when we talk about a strong commitment, we want to talk about a strong commitment to training and workforce development, which is also key to what we're doing at NINR. And it's this impact which will allow us to have sustainability and to make sure that we are doing what is necessary to carry our science forward. Next slide, please. These areas reflect where NINR has built depth and where we will continue to invest. They're organized around key dimensions of health, so we're looking at context, distribution of information, prevention and management, and a systems-oriented approach. But importantly, these are not static categories. As we continue to evolve, we will notice that the areas of inquiry will evolve as well. But part of what we're examining now is whether to continue to represent and if we have the right structure moving forward. This is where we will need your help, is in having a conversation about the priority areas that we need to take next. Next slide, please. But to just be a little bit more concrete in terms of the activities we're doing, I'm going to highlight a couple of examples of how the work that we're currently doing and how it's being operationalized. Just keep in mind that this is illustrative and not meant to be exhaustive. We are doing quite a bit of work, but just wanting to give a few examples of how the work we're doing really fits into the framework. Next slide, please. So this initiative focuses on health within school environments and the greater system outside of the actual school setting. It reflects a systems level approach, integrating education, health services, and the environmental context. For us, it's a good example of where nursing science is well positioned to address complex, multi-level problems and where implementation is central from the beginning. Next slide, please. Community partnered research is a core methodological approach that has been within our portfolio for quite some time. It has allowed us to develop interventions that are not only effective, but to ensure that they're feasible and sustainable. And quite frankly, I will say very proud of the longstanding history that NINR has had in this area and would love to continue to be able to serve as a leader in this space. But it strengthens our relevance and the generalizability of our work. Through our P20 Centers mechanism, which we just recently released, we're hoping to build a cadre of programs across the schools and colleges of nursing that provide the infrastructure necessary to conduct such important work. Next slide, please. In relation to maternal and infant health, this is an area that remains a critical area and a critical need, as we continue to see by the research that continues to move forward. NINR has played a leadership role in the NIH-wide Improve initiative and will continue to do so. It reflects for us the importance of the issue and the value of cross-IC collaboration, which is another aspect that we would love to hear your voices about as well, in terms of partnering across NIH to ensure that we maintain our relevance for the science that we're doing and to also uplift the importance of the science that we are conducting. Next slide, please. And of course, I would be remiss if I didn't talk about the importance of AI and technology. We're seeing a significant opportunity in data science and AI and an open invitation from across NIH to partner and to lead in this space. Nursing clearly contributes substantially to the data infrastructure underlying these systems. We have to be involved at the outset, not just as users on the end of something that's already been developed. This is going to create an opportunity to shape how the tools are developed and they're implemented following, particularly to ensure alignment with real-world workflows and patient needs, fully understanding that in many cases, our nurses who are doing the clinical work of the discovery have shown and have indicated in several places that by the time the technology comes to them, it doesn't necessarily fit what they actually need to be able to help patients, families, and communities. Next slide, please. But we are also at a crossroads where it is so important now for us to sustain the field, and it's going to require sustained investment in people. We're going to need to support scientists across the entire career spectrum, from trainees to established investigators, and that's going to include both individual and institutional mechanisms, as well as making sure that workforce development remains core to the priority. One of the things that we have done historically, which we will love to continue to do, is to support our trainees and to provide mechanisms at NIH and NINR specifically where we can do that. Next slide, please. And I'll stop here because honestly, the point of today is not to hear specifically from me. I'm here to be an active listener, but I want to make sure that we have time to move into the discussion, particularly focused in on a few things: where the science is the strongest, where we can sustain it, and where there are emerging opportunities for NINR that we should consider. So I appreciate hearing your input as it will directly inform our next strategic plan. And I am now going to turn off my camera and go into listening mode. And thank you very much for your time.
Okay, well, thank you, Dr. Aklin, for providing an overview of NINR and the context for today's listening session. I would like now to invite our FNINR board members, Dr. Donna Bliss, board member, Dr. Ashley Dorsey Mahoney, board member, and Dr. Diane Morrison Beatty, board member and secretary, to participate in our live discussion. Each will take turns responding to questions that will appear on the screen. We ask that you please share your responses throughout the session using the Q&A feature. Keep comments forward-looking and centered on opportunities and research priorities. Again, hopefully comments will be concise, phrases are perfect. So let's get started with our questions. We will provide a slide set that each of you can see with those questions. So our topics are emerging science and innovation, nursing scientists / research workforce, conditions of daily life, translation and implementation, partnership, systems and settings, and other questions that you may have or would like to comment on. Okay, so emerging science is going to be our first topic, and that will be Dr. Donna Bliss, and she is going to talk about and answer this question for us. As science continues to evolve, where can nursing research have the greatest impact?
Thank you, Terry. And I'm also going to address the second question at the same time in my comments. What innovations have the greatest potential to accelerate progress in nursing research? And as Dr. Murray said, my response is to start the conversation and help stimulate your ideas to be posted in the Q&A function. So in terms of impact, the core aim of nursing research, which has been to improve health, quality of life, and well-being for individuals, families, and communities, I believe is still relevant. There are various evolving questions, for example, related to cancer survivorship and immune therapies, but we still not have solved issues related to birth outcomes, how to prevent and live well with chronic conditions, provide opportunities and environments for youth to have safe and productive futures. And here we are back to the future on prevention of infectious disease and immunization effectiveness. In terms of innovations to accelerate progress, as we saw in some of the priorities of NINR, I suggest that nurse researchers continue to develop and incorporate various technologies such as machine learning and other informatics methods, wearables or body-worn technologies, mobile or web-based apps, virtual reality and augmented reality, and AI as tools to strengthen our clinical research and expand the scope of the answers we're able to provide. And I say continue because nurse investigators are already doing this, but we need to continue into the future. So I will be very happy to read any questions, either in response to what I have said or additional ideas that would be typed in the Q&A.
So Donna, I may ask you a follow-up question about emerging science. At which levels, individual, family, community, or health system are the greatest opportunities for impact?
You know, I think this relates to a future question that we have, Terry, in terms of partnerships. I think there's potential for partnerships at all of these levels. I think we want to collaborate with our colleagues in practice and healthcare systems to generate the questions that are of interest to them, but we still have individual level research that continues to be important that we have not solved. Someone asked a question, can there still be a focus on symptom management at the individual level? I would agree with that. I would say yes, we haven't solved or come up with all the effective therapies at the individual level, but I think we really need, sort of this portfolio where we have individual as well as community level issues because nursing is involved in all of those levels. So we're suggesting these things in this listening session to NINR as to include in their portfolio. So I would say, Terry, that no one area really at this point has been at a level where we've resolved that we still have questions in all of those levels that still need to be answered.
Thank you very much, Donna. One more question, and you may have covered this, but if you can expand on it, what innovations have the greatest potential to accelerate progress in nursing research?
I would say, incorporating technology. That really is a new method, and it really has been able to expand our capabilities. There were questions in the past where we didn't have the tools to be able to come out with, or the tools or the measures to be able to come out with the measures. And I think these new technologies are really going to expand our capabilities. There is another follow-up question was a comment. Perhaps we should, have a focus not just on completely new approaches, but to, really continue to forward some of those previous priorities that we've had in nursing research into the future. I think that's a very interesting comment, to sort of evolve and grow various areas as well as add new ones. Here's one that says, can we describe our research on prevention, treatment, and community health that have lost grants because they're not on topics that the current administration does not like? And here's another one. The NINR position nursing to lead development and implementation of AI within the electronic health record, and these tools can reflect nursing priority workflow and patient-centered care. I really do think nurses need to be in the leadership and vanguard of targeting those technologies to those questions that are important to nurses. Various disciplines are using those technologies for their own interests, and so nurses also need to be involved with that.
Thank you, Donna. And I don't know if I know Dr. Darcy Mahoney was going to talk a little bit about the question about social determinants of health. I don't know if you want to pipe in now.
I think
Or
for the question to come, but I think it's a really important one. So I'm very happy to talk about it and how we can continue to evolve our science to think about that and where NINR hopefully will continue to go.
okay, thank you. So we'll have more on that a bit later. Thank you.
And there is a question, excuse me, Terry, there's a question about workforce in the Q&A section, but I know that's coming up next. So I will let Diane address that one.
So we will go to emerging science if there is nothing else. Nurse scientists and research workforce. What is needed to develop, support, and sustain strong careers in nursing research? And we will give that question to Dr. Diane Morrison-Beatty.
All set? Okay, so thanks everyone for being here. I also chair advocacy committee, and that's involved with our ambassador program. And since there's about 80 of you here, there's probably 80 people that could serve as ambassadors. And I want you to know we have less than 50% of the states covered now by ambassadors. So please consider that uh, and have your voice heard through this mechanism as well. So I'm going to talk just a little bit. I guess it would be kind of the state of the science, or as I say, the state of the challenge of the neuroscientist research workforce. And just to kind of get all of your brains in the same kind of way of thinking, because this is using a CBPR approach Dr. Aklin wants us to use. So really it's about you responding to kind of the state of our challenge here, and just with ideas, shooting out ideas, questions. Do not hesitate, because the more data Dr. Aklin has to take back to her team, the more it's going to help us in our mission to move nursing science and funding for nursing research forward. So just want to emphasize that. We all know we're faced with the ongoing shortage of PhD prepared nurses and nurse scientists. And as Dr. Aklin was saying about how things are connected, that has ripple effects across not only research, but clinical practice, education, the whole health of the community and the nation. We know there's a limited pipeline of nurses pursuing doctoral education. There's, the whole draw of, is it financially more lucrative, or do you get better professional returns without a doctoral degree? And those pursuing doctoral degrees, we have a plethora of options. And sometimes the PhD is considered the slightly longer option for people. And so that's been a challenge for having sufficient numbers in the PhD pipeline. We also know the Department of Education just reclassified the degree professions that can apply for professional degree loans, and that doesn't include nursing, and that ultimately will cause financial challenges for those pursuing more costly or longer in time degrees. We know within academia, without all the financial constraints that academic institutions are facing right now too, there's shrinking scholarship support, especially for those pursuing doctoral degrees, especially for those pursuing PhD degrees. I don't know many institutions that say we have a lot of PhD funding for students. So be thinking about that in your responses. The number of stipends, tuition support, et cetera, are limited, but NINR does offer us an opportunity of what could potentially be available if you want to talk about to NINR in these discussions about what you think would be most helpful for PhD support. Along with the kind of restricted pipeline of people coming in, we've got the aging current workforce of nurse scientists. And this is going to be a big challenge for us, because we know those nurse faculty scientists are being asked to do more, not necessarily just focused on their research, but more with teaching, service activities, etc. So it can negatively impact the availability of seasoned mentors who could move that group of new PhD and nurse scientists forward more rapidly. If you think about those constraints, it all affects the advancement of nursing science and evidence-based practice, which really could limit us in our ability to generate discipline-specific knowledge. So we've got limited funding opportunities, mentorship gaps, challenges to faculty, both those incoming students into the pipeline and those that are at the end of the pipeline, wanting to continue their research, wanting to mentor, but also we've got quite a large group that's going to be retiring over the next few years. So when you think about these challenges, these opportunities, okay, what messages or questions do you want NINR to hear from us on this? What do we need to develop in regards to moving people into the pipeline, supporting them, and sustaining careers in nursing research? So let's see if I can see all the questions popping up.
And
Is
Diane,
this, yep, go ahead.
okay, before you get started, I just want to iterate to our audience that their role is to provide responses in the Q&A, because the floor will not be opened at the end just because of the number. Our floor won't be open to verbal responses. So please share your comments in the Q&A. That information will go straight to NINR, and it will be part of the record as as they proceed to develop the strategic plan. And can I ask you two follow-up questions, Diane?
Sure.
Okay, so you talked about the dearth of nurse scientists. So, how can we foster early interest in research within nursing education and training?
If you're asking me specifically, I hope other people are going to answer in the Q&A. I think one of the challenges, I think one of the challenges that early on when students enter into nursing programs, how often do they actually meet with, are taught with nursing researchers? A lot of times that's held out till the end. People in their master's degree, people who are considering doctoral degrees. But if, as a new nurse, I've never seen a nurse scientist and can't connect the pieces to how nursing science still makes me a nurse who is practice ready and practice active, which is always a challenge with students. Oh, I want to practice. I consider research part of what changes practice and is just as much important to practice. I think in academia, we really have to start thinking about getting our nurse scientists up front and center early, early, early. Not just in honors programs, not just in those that are BS to PhD, but across all levels of students coming in. So they really can see the diversity of roles that are available to them.
Thank you. And Dr. Dorsey Mahoney, did you want to comment on that?
Sure, I'd be happy to. I actually just had a recent experience with our GW Student Nurses Association, where a colleague of mine from Australia, Dr. Bron Griffin, who is a nurse scientist studying emergency room and kiddos with burns, we had this discussion on how they'd never met nurse scientists until we'd had this sort of fireside chat. And I'm a clinician scientist. I've considered myself that for a long time. I know it's been something that nurse PhDs have perhaps shied away from over the decades, but it's something that a lot of folks have been moving towards and seeing our physician colleagues in this area. And I think that as we just discussed, and as Diane was sort of saying, I think this is a real opportunity to think about where we can intentionally grow and support nurses that want to be clinician scientists embedded across diverse care environments, not just academic centers, but also places where health is experienced, like health systems, primary care, schools, public health settings, places where we haven't always had nurse scientists either, but where we have folks that are really interested in these clinical questions, these clinical science, new knowledge questions that we can begin to answer. And I absolutely agree that really, can we put nurse scientists in front of our emerging students, our traditional students, our accelerated students, our direct entry master's nursing students, so that they can see what it is to be a nurse scientist or a clinician nurse scientist and the different pathways that might exist for them.
Yeah.
Can I flip to some of these Q&A questions and stuff?
Mm-hmm.
I know there was a question about, is this about the research workforce and nursing workforce or in general? And I think, yes, we know the whole linkage between research practice and teaching. So I think what NINR wanted was really to hear especially about the nurse scientist research workforce, but certainly they're all connected in every way, shape, and form, to tell you the truth. We need to investigate, promote more BSN to PhD students. Agree? Financially, how do we do that? I think what I'm, is, are there different opportunities, or do we just need more effort and monies directed toward training opportunities? And I'm going to mention this at this time too. How do we support the mentors who are needed in order to provide all that mentoring experience? And do we have enough support for senior investigators to keep mentoring when they're being asked to do so many other things on top of it? Is there a way to generate a pathway to the PhD starting in undergraduate education, perhaps like T32 grant mechanisms that can support such pathways? And I think, Terry, do we not have something like that was attempted?
There are training grants. I think
the training grants
now and moving forward might be what skills are needed to lead impactful real world intervention and implementation research so that as NINR receives this data, your comments, when you think about what skills are needed, what programs are needed, if you put that in the Q&A, that information will be fed directly to NINR so they can take that into consideration as they form their strategic plan. As Diane said, this is a community-based, participatory approach. So we're hoping not only from the comments from our panelists, but also your comments so that all that information can be filtered into the process.
You know, Diane and Terry, this is
Mhm.
Donna. There are some comments and questions in the chat as well as
Oh,
the Q&A. And one of them, I think that is relevant to this, was the suggestion, might mentors, faculty researchers, I'm assuming, be somehow shared across schools in nursing, since every school doesn't have all the expertise and students can't always go to different schools. That's an interesting idea, but just wanted to call your attention to that, Diane, looking in the chat.
yeah. I think, we're going to have to be smarter about things because when you start counting the number of funded or those with rigorous programs of research that have been ongoing. I remember one faculty member who retired saying to me, "Who is going to carry on my program of research?" So while we want new emerging programs of research and areas of funding, at the same time, somebody had brought up, how do we keep those interventions that are being developed? Maybe they aren't in the translational stage yet, but they could be. But now we have somebody who retires or steps out. We don't have students that are following them, carrying on the pathway, and that science just kind of goes kerplunk. So sorry, I could get on this bandwagon for a long
Yeah,
time,
and I
but I'm
think
gonna.
there's also a comment in the chat about, new faculty who have been trained by mentors, and now they're concerned that that future funding is no longer available for what they trained for. So
Yes,
that continuation as well as new areas seems to be really an important topic.
yes, and a concern for people. And I think the whole thing about can we share mentors? Can we share, um, you know, training programs across topical areas? I don't even know if this is possible, but instead of one school getting a training grant, could they help with other institutions with like-minded students from across the country to be trained through that setting? I don't know. I don't know how you would do it, but we got to think differently. We have to think differently because we can't fill the gap fast enough.
And Ashley, there's a
Good.
question here for you, probably. What do we think about 50% academic and 50% clinical appointments? Seems like academia and funding can't match the pay of those in clinical positions.
Yeah, I think this is a really great question and one that's probably pertinent to the discussion of the strategic plan, but maybe not one that NINR alone can actually fix. This is maybe something that really our academic institutions and our hospital partners will have to talk about. But I already think we have a model for this. We have physician scientists in schools of medicine who have active clinical practices and active NIH, either social science programs, behavioral programs, lab wet labs that are already doing this. We have great colleagues that we can look to towards how this can already be set up, structured on both tenured and non-tenured trajectories and lines. I think that it's a little bit easier for the nurse practitioners who have billable hours in the same kind of way that our physician colleagues do. But I do think that as an academic institutions and as universities are thinking, how can we do this with our bedside nursing colleagues? How can we do this with our colleagues that want to stay at the bedside as registered nurses and scientists to be able to do this? Because most of the models we see really align with our advanced practice nursing colleagues and PhDs, but there are ways that I think we as a groups of researchers and groups of faculty will have to come up with some of these strategies that may be outside of the strategic plan that NINR is putting forward, but maybe supported in clinician scientist routes like these T32s, these K23s, K08 grants, mechanisms that allow for that clinician scientist role to be more robustly supported at NIH.
Thank you, Ashley. And can I remind our participants, because I know we are getting a lot of communication in the chat, but please put it in the Q&A, because that information is where it will be shared with NINR. We're capturing all Q&A questions and comments.
So if you can't find, if you go under more, there's a Q&A and hit that and put it in, because NINR really wants this information. And I think we have a lot of, common support for training and funding mechanisms beyond just the T32, F31, F32 into other P and K, further step awards for people to keep supporting as the nurse scientist goes through their career, other opportunities for advanced training and mentoring in return.
Okay, are we ready for our next question?
We probably could. We could probably talk about this all day, but thank you very much.
Okay, so our question, this is regarding the conditions of daily life. How can we determine what works for whom and in what settings when implementing nursing research and practice? And I'm going to throw that one to Dr. Ashley Dorsey Mahoney.
Yeah, great. Thanks so much. So I really appreciate the opportunity to sort of reflect on this question as a broader conversation around NINR strategic planning, because I think these are the questions, as evidenced by some of the ones we already have in the chat, that are sort of exactly the ones that are top of mind right now as we think about scientifically rigorous and maximally relevant to the sort of years ahead that we're doing the science. So I'm going to speak a little bit from the I and then try to bring it forward around what I'm seeing at NINR and what I think I've heard in the nursing community that we're hoping for. And I think this question sort of sits at the very heart of what nursing science is, because it recognizes that health outcomes cannot be separated from the conditions in which people are born, grow, learn, work, play, live, and age. And nursing research embodies that holistic perspective, but also not just the whole person, but the whole context with which a person exists. And that means understanding that the same intervention may not have the same effect across populations or care environments. And if we fail to account for the realities of daily life, poverty, food access, language, housing stability, education, transportation, social supports, trust, for me, it's not just the question of does an intervention work, but as Dr. Aklin said, it is also what works for whom and in what setting. So in my own work, some NIH-funded work that I've done, we've used technology to create a bilingual, culturally responsive intervention, language intervention for Hispanic moms and babies. And using the developmental science of caregiving and serve and return responsiveness, we sort of are supporting this early brain and language development. We can also look to Dr. Hudson Santos's work, also NINR funded, and his community-driven interventions on Latina mothers, recognizing that obesity-related outcomes are not simply a matter of individual behavior, but an interaction between biology and environment. And whether families live in poverty or have access to healthy food, opportunities for exercise, this is a really important way in which we have to culturally tailor our approaches in neighborhoods to interventions that we want to help for the people where they are. I think NINR has a tremendous opportunity to continue this work, to identify effective approaches to improve health and well-being by addressing those conditions of where people are living and determining whether these interventions perform the same across populations and communities. And so one of the questions we had in the chat was that Dr. Voss put forward was the language in which we can say some of these things and describe in our research. And I think NINR has already begun to model some of this for us within their current strategic framework, emphasizing terms like optimizing health for all, differences in the distribution of health and disease and conditions of daily life, and thinking of these as scientific constructs that allow us to ask measurable questions. And so perhaps instead of some of the broader language that we used to use on social determinants of health or health equity, really honing in on perhaps the measurable question we're asking, whether it's about neighborhood, whether it's about race, whether it's about the environment or perhaps the environmental pollutants that exist, right? What are the measurable questions in the variation of outcomes, the barriers to intervention effectiveness that can influence health across populations and settings? I'm not sure I have all of the answers, but I think as NINR is thinking about these strategic planning and what they've already shared with us, these are the types of descriptions and real focus on the terms that can better allow us to measure outcomes in a more discrete way.
Ashley, can I ask you and our audience participants via the Q&A if you would speak to what non-biological factors should nursing research address to improve health outcomes?
Sure. I mean, I think there's probably quite a few. I've mentioned some of them. So thinking about perhaps like environmental factors, those of us nurses that are interested in climate change, climate differences, changing of air pollution for asthma outcomes, things like that, right? I think that's an example of one. On a personal note, I'm very interested in the Childhood Opportunity Index, which measures quite a few variables in which a child lives and plays and learns. So whether they have a neighborhood that has safe sidewalks and safe playgrounds, early childhood centers where they can learn from the start of their life, 0 to 5, prior to school education happening, whether they can get transportation to those centers, right? I mean, these are the types of things that I think are really important to interventions. Again, I work at the intersection of prematurity and high-risk babies and long-term outcomes. So those are the things that I think of and focus on. We have a lot of things in the chat, so I'm going to try and read them as we go and try and make sure that I'm capturing this. I know this conversation is quite big. And so I'll just read a few of these so that we make sure our NINR partners can hear them and make sure people feel heard as well. So some people have said, I don't think any intervention will work without person-centered care. It can be approached from an individual level through system and policy level. Certainly just like Bronfenbrenner, where a child sits at that middle and we move outwards. Non-biological factors also can include loneliness. So yeah, I really appreciate that commentary as well. And the commentary of a mistake to leave biology out of our holistic perspective. Exactly right. Biology is sensitive to our environment and may provide early markers of concern. And I think that's really, really important, right? It's not necessarily that to separate the two, but how does genetics and environment have an interplay? My work on neurodevelopmental outcomes, specifically autism, is an example of this. There are many, many other examples: prematurity, maternal health, and stress, right, of where the environment interacts with biology to perhaps create an outcome, and where can we intervene as nurses. So really appreciate that commentary as well.
Okay, there again, continue to put your comments in the Q&A, any questions that you may have, any feedback that you want NINR to receive, and we will move to the next question. Translation and implementation. Where are the greatest opportunities for nursing research to translate evidence into real-world clinical and community settings? And I believe that is Dr.
Me again.
Morris.
Yeah. Okay, so please make sure you add comments and ideas and thoughts because overall we face several challenges, both structurally and workforce related to, I would say, building, sustaining intervention in translational science at this time. We talked about the limited PhD nurse scientists trained specifically in intervention development, implementation, and dissemination methods. And I guess I want to pose a question to this group. How many of you know within your institution, at least, if not other institutions, that are encouraging students to move away from conducting pilot intervention research for their dissertation in order to get them through the pipeline quicker and faster? And what are you encouraging them to do instead? Secondary data analysis, systematic reviews. I'm just interested because I hear from students who want advice on intervention studies that they're being kind of pushed on a different pathway. So that's a question added to a question. So, we have challenges with infrastructure within settings, both the academic setting, as far as intervention research, costs more. It's different than doing a secondary analysis. It takes more time. It takes more studies to build up to that step of intervention research. And you've got that being challenged then with what's expected of faculty scientists within their roles within academia. And then within clinical settings, it may be that frontline nurses or the DNP nurses in there that would be your partners also are facing time challenges, training challenge, or institutional backup or support for moving evidence into routine care. I know clinical agencies would love all the evidence made available, but in order for evidence to be available to change patient care and improve outcomes, we need to partner together in order to get the evidence. So I guess I would just say to you, where do we sit in regards to, and this is kind of comments back to the PhD and supporting more senior people, of moving many of the interventions that are in process in people's programs of research, maybe not all the way to the ultimate point of translation into practice, but could move there. How do we support those opportunities as well as building new opportunities in translation and implementation? I think NINR wants to know when it comes to the greatest opportunities, what are you thinking our opportunities are? Gotta flip my little camera thing here. Be mistake. I know you have things to say. Okay. Um, we still need observational epidemiological studies. Agree? Agree. Yeah, absolutely. The need for science across all different areas is critical. And I think to me, that's an important message NINR needs to hear, that strong science is needed in all different areas, not just in, the hot topic of the day. I'm sure NINR will let us know in the future if there are any summer institutes planned. How can we have a social media presence from NINR where scientists inform the public in a fun and engaging new way? That's a new opportunity for NINR to think about. Okay, Kristen, I'm reading. Due to program time constraints, fewer PhD dissertations build and test interventions, and not all go into postdocs. Absolutely. How can NINR training mechanisms enhance innovation and rigor early in the nurse scientist career? I think this is really, really a critical question if we're going to keep moving towards actual translational science.
Diane, can I read one out loud
Yeah.
that I know you've discussed too?
Yes.
Really appreciate this one. So it says the current director has noted that we, not just nursing, can't keep describing a need to get to solving health problems. I
Yes.
do think we need description to be clear about the problem and the parameters, but we have too much of that. This is again a quote. We do need intervention work. We can't be translating and implementing interventions that don't work. Can you comment on this? I feel like this is one you
Sure.
talked about.
Sure. Yeah, and I will give a shout out to NINR because they supported every one of my research studies that helped to move from descriptive early on in the dissertation phase through pilot and then full-scale RCTs that are now being used by communities and different countries for my intervention. So thank you for that. But that took years and years of support and mechanisms that supported those building blocks. And I think when we talk about kind of scientists mid-career, more senior scientists, where is the opportunity for them not only to mentor the generation coming in so they learn implementation science and learn full-scale RCTs and moving trials into communities, but also support and move forward. I think we've all, I hope, all gotten the message we can't describe, but we also need enough financial support. I'm just going to say this personal opinion coming here. How many of you have thought that you really needed 5 years for a full-scale RCT in communities, et cetera, that are pretty complex, but we're all encouraged. It's got to be only 3 years. It's got to be only 4. You're not going to get funding for 5 years. So I ask NINR to also consider that challenge or what can be accomplished on those budget numbers in a 3-year period that moves the science forward.
Diane, I can add the other thing that would be really helpful is if our participants can also lift up things they feel they have seen that's going very well. It doesn't even have to be nursing science, it could be in another discipline. If there's something you want NINR to know that has gone very well and you think we should take a look at that within nursing, please
Mhm.
feel free to add that into your Q&A remarks as well.
And how would NINR like to know? I'm just saying this. So if you have someone, I'm just going to use myself as an example, who's been funded by NINR throughout their career, who has an intervention that's being used now, translated, implemented into communities across the US. Other people I know have. How do you get that information? How do you know? How can you have those success stories to tell? Because that's what long-term support of a research career can do and what outcomes can be available to our communities. But once that happens, I'm not really sure how NINR finds that out unless we send you a little message or text you or something. Um, I would be interested in knowing that. Let's see. Joaquin, many PhD programs tell their students that intervention work comes after the PhD. How can we shift this notion? Yep, agree. Okay.
And maybe how can we teach it? So maybe this is an opportunity. NINR put out that R25 last year. This perhaps is an opportunity for something like that, where we could really, have a need to teach the next generation of nurse scientists about intervention work, RCTs, alternative consent models, how we can do that and build a cadre of nurse scientists that are able to do that, perhaps in a different type of mechanism that perhaps lives outside of a PhD, maybe lives outside of a postdoc, in ways that NINR has funded more recently. And so perhaps your point, Terry, of what NINR wants to hear goes well. I think that R25 mechanism, some of the examples with NPATHs and the firearm safety one, firearm prevention and safety one that are out, I think have really gone well to help build that sort of educational need within doctorally prepared nurse scientists. So perhaps that's an example.
Thank you. I have
Excellent.
another question along this topic too, is how can we better engage practicing nurses in adopting, applying, and contributing to the translation of research into their real world practice setting? Because we want that
Yeah.
translation. So please put comments and ideas in the Q&A.
Yeah. And thoughts are, I mean, first you have to work through the people that supervise or oversee um, leadership within those organizations because they need to be on board. If nurses at the bedside are getting the message that this is not important or can't be a priority, they aren't going to focus on that. But if your CNO comes down and says this is really critical and we want to help you be able to do that, I think you're more likely to find academic partners than to say, okay, let's make it happen. Let's figure out how to work together to make that happen. So how do we work with leadership across organizations outside of academia to provide them with necessary expertise as well as to gain their support to move that forward in clinical settings? I like somebody anonymous. I'm just going to say this because I think this is important. I think creating more opportunities for undergrad students to participate in meaningful research. How about supporting summer research opportunities for undergraduate students? And could that be something that NINR could be interested in? I'd like to
Great
see more
question.
R2133 type opportunities. And of course, people are talking about the expense of translational research and doing community-based research, which, yes, it does. And it takes long-term commitments with external organizations or communities, not in for a quick study and out, you never talk to them again or they never hear from you again. that takes time and effort ongoing to develop and establish and maintain that program of research in communities.
I'm going to pop in.
Ashley?
Yeah, I'm going to pop in and do the next one that's come up because I've said it a few times now. I think a big part of translation and implementation is maintaining proximity to the bedside. Translation becomes difficult when you haven't seen the setting you're implementing in. And I echo the comments before about maintaining practice. Some of the most accomplished nurses or NPs I know are delaying PhD applications because they don't want to give up their practice. As someone who continues to practice as a nurse practitioner in an ICU setting, and is a tenured professor, I can tell you this has not come without lots of different pain points along the way. I've had really incredible deans who have supported this, but not without pushing and asking and discussing and talking about why it matters, how my research can be built upon some of the practice work that I do, how the questions that I want to answer come straight from families and patients. And for me, and I will sort of say this maybe little bit vulnerably here, but how it also creates a sense of joy in my work for me in the practice brings me a great sense of joy and contentment in my work. And I'm not sure that I would have been able to say that in this type of forum, as a junior faculty, but thinking about the really large, robust population of practicing clinicians that want to be nurse scientists and don't do so for a variety of reasons, because perhaps they're told they can't, they don't think they'll be able to get tenure, or the economics of leaving a nurse practitioner or a nurse anesthesia or nurse midwifery CNS job may be economically not feasible for their families with an academic appointment. And I think these are some things that we really have to come to real discussions within the nursing community, because we have a lot of nurse scientists or burgeoning people who would like to be nurse scientists that are in the bedside and don't want to give that up. And I don't think many of our physician or other clinician scientist colleagues have had to do so. And for many years, we've said that nurses do. So how can we rectify that? Where can NINR's strategic plan help us build in that way, help us build in these partnerships, which may be what we're leading to, Donna, in the next discussion.
Exactly.
Build these sort of partnerships together to create a more robust clinician nurse scientist route that I think has been percolating up with the new generation and perhaps my generation of nurses for quite some time.
I just want to add a couple of comments that were earlier seem to relate to this is funding for translation. So it seems there was some comments about more experienced researchers getting funding and not new researchers. And then other comments talking about, well, if you get funding for one study, you then need further funding to get those results into translation, into practice. So it isn't just like a one-time because we want to spread out the funding, that if it really is important, it's going to need more of this continuum of funding, and how do we manage that as well as fund our new researchers. So I just thought that was an interesting point. So I think we're ready for partnerships.
Yeah, Donna, I think so. Let's put up the next question, please. Partnerships, systems and settings. What partnerships and collaborations could strengthen the impact of nursing research? And Donna, I'm gonna go right ahead to you.
I would say some of our best partnerships are our colleagues in practice. We have talked about that in several different ways in this discussion. And so that and partnering with our nursing in healthcare systems is also important. There were several comments about the technology piece, and one of them was about, well, we need to fund more nurses to become trained with AI and machine learning and informatics technology. And then there are other comments they're talking about, well, not every nurse can be expert in those technologies. And I think both are true. We do have nurses training in these new informatics type areas. But myself, I am involved in developing a mobile app, in innovative educational simulations, virtual reality for cancer patients. And I am not a software programmer to do these. And so those partnerships with small and large businesses, with experts in those technologies to get their interest and their support for our research questions is really an important partnership. Someone raised the question about vendors who have electronic health records, who make all these changes in electronic health records that impact nurses in the clinical area without really testing their validity or their relation to nursing practice. Maybe we need incentives to get those companies to partner with nurses on the type of changes that would be made that would impact the nursing workforce. And this is not this isn't a last and least, but it's a very important aspect, is to partner with individuals and communities because they're stakeholders. They should be viewed as stakeholders in our research, not only to offer us questions, but to partner with us in developing the solutions and then implementing them in those groups. And I guess I would like to also add for NINR to really be open to investigator-generated research proposals, because if the researcher has been grounded in these partnerships and have been listening and develop a proposal, perhaps that's the best idea, brought forth, as opposed to dictating what really should be funded, to keep that opportunity for investigator-generated research available. And so I'm looking here, some of the other responses is partnerships between health systems and school and nursing is important. Collaborations between PhD programs and school of nursing, is there a way to help have more of that and to fund that? The idea of it's very difficult to, the financial support for those who are in pre and postdoc fellowships, very difficult to have a living on. Global health initiatives also, continuing to support them, where there has been some decrease in interest in funding those, really global partnerships. I didn't even think of that. That's a really good idea. Ashley, perhaps you can also, if you have any other ideas, address that before going to your question.
Sure. I think maybe the one of the questions that that I can take, that I was going to address in my commentary, but happy to just jump to it, is the NINR, and Dr. Aklin has mentioned a little bit about school health and some of the partnerships around school health as a community setting. And so one question that was asked is, what can NINR do to partner with schools and school nurse researchers to identify effective school nurse interventions and move them through translation implementation process? And so actually it was a little bit part of what I was going to comment on, also was noted in the Future of Nursing report as well. And so I'd like to just sort of jump to that, in that schools are often one of the most underutilized health delivery platforms in this country. And school nurses are frankly the ones managing chronic disease, mental health concerns, food insecurity, family linkage to these services. And we've underinvested in research examining school-based nurse-led models of care for a very long time. And I think if we're serious about optimizing care delivery, we absolutely have to think beyond tertiary care centers and clinics to where families are and where kids spend their daily lives. NINR is leading in this, and I do hope they continue to lead in this effort, as Courtney had mentioned, thinking about what is working well. But we also have to think about partnerships between school districts and public health departments and youth services that can really allow us to rigorously test these nurse-led interventions in asthma management, obesity prevention, and developmental surveillance. And I do think one of the things that may come out of this, for those of you who do sort of health systems science, is where are the gaps in care delivery, and not just in the discovery of intervention. So in care coordination and continuity and staffing structures. School nursing is just one example of where you could answer a lot of those questions, but it's not the only one. And so for those folks that are interested in thinking about patient to nurse staffing ratios and how it saves lives and money, and how we can think about where nurse science is not just simply discovering interventions in isolation, but how the health ecosystem and where scientists are embedded in those ecosystems delivering care are really important. And so I do think the sort of health systems and payers part that has come up here. Again, one example that I led with was the question in the chat around school nursing, but it's not the only one. So just want to think about those types of partnerships too.
You know, someone on one of the more recent comments in the chat, I think is true. We need to increase partnerships between nurse researchers and our nurse practitioner colleagues in practice. I know when we started our DNP and nurse practitioner programs, the vision would be that they would partner with us in research from the clinical area. And there's, you know, maybe a lack of that component of their education to help prepare them to collaborate in research with nurse researchers, and not just, of course, as data collectors, but as, you know, meaningful partners in joint research between practice and clinical. And so looking at our academic programs for nurse practitioners and DNPs to really help strengthen that and give them, you know, that catalyst and that foundation to do so.
Okay, I will ask our panelists then, as we are approaching time, we have about 15 minutes left. So I'll start with the panel. Any reflections, any thoughts, anything that you believe or you've read in the chat or in the Q&A, major themes that should come forward? Are there any other questions or items that we didn't address where we can use these last few minutes to discuss those things?
I don't think we've talked much about what intramural research looks like at NINR. We've talked quite a bit about the extramural research programs, but we haven't talked a lot about intramural researchers at NINR and what we hope the strategic plan looks like for the intramural scientists at NINR. So that's something that I'm wondering if people have any thoughts or commentary on.
And someone had raised the question about in the past, NINR had in the summer had hosted some undergraduate nurses for a campus visit to look at what intramural programs there are and to really sort of talk about nursing research. Is that still being done? Could that be done, you know, to get that interest early on was a suggestion.
And Diane, did you have anything to add to that?
I guess I'm just thinking, and this isn't just about the visit to NINR and NIH, but how do we also show interested students, potential doctoral students, non-lab based research efforts? How could we get that out? And somebody had brought up social media, but it would be interesting to see how we leverage social media to get stories out and visualizations of research in communities, which can look very different from research at the bench.
Yes.
One
So
And I know there's also comments here about other different types of mechanism than has NINR. I know we have our budget is our budget, but have they thought about looking at other mechanisms that may be more needed at this time, like SBIR, STTR, uh, 34s, whatever, as well. So I would just say that.
Yeah, and I
And
think
I just want to remind our participants to please put your thoughts on what was not covered in the Q&A, because again, I can't emphasize enough, we really want to capture your comments. So please, all of this is recorded and will be sent to NINR. So please put those comments there. If there are things that you have thought about that we have not mentioned, we want to capture that.
The good thing too is if you go home tonight and then say, "Oh, I wish I had brought this idea or whatever." NINR, this is not NINR's only listening session. There's going to be multiple. So there will be other opportunities, hopefully, that you can connect to in order to have your ideas out there.
yeah, two comments that I think have been touched on throughout. So the first on the intramural question that I brought up, one of the comments was really needing to explain what is actually left of intramural research at NINR. And I think it lends itself to actually two other points that have been brought up in the Q&A and also by Diane at different points, is really maybe promoting our work and also promoting what's happening at NINR to both our community, right, the nursing community, but also to Congress and to our legislators and to the folks that are going to be creating the budget, so that they know what science is happening at NINR. And so I know we talked about that in advocacy, and so I'll plug again advocacy at FNINR, but also plugging advocacy in other ways that you can do so. And social media is one really important way. So thanks for that commentary in there.
And I
Yeah,
want to
and
add
copy NINR and FNINR, et cetera, on your social media post, please.
And I
Tag
will
us.
add to that, the more you can let our legislators know the value of nursing research, the better. The legislators are the ones who appropriate funding for what NINR can, the funds that they have to allocate. So we need to keep first and foremost in our legislators' minds that the value of nursing research, because we've been on thin ice and we're moving forward this year with not being up for elimination or any of that. So we want to make sure that that value of nursing research is told nationwide.
And
So
everyone here who's on this call here has something to say about nursing research. And really, the ambassador program is about getting the message out to those representatives and helping them understand in easy terms, which we're good at, what nursing research is and what impact it has. So I'm going to make another plug. Whatever your stage of your career, please think about serving in the ambassador role, because we need far more than we have right now, even though we've probably quadrupled our numbers. We started small, small but mighty, but we need big but mighty, big and mighty.
so I guess with that we will move to our last slide. And it has a recap of the questions that, so when, if later the next day, next couple of weeks, if you think of any comments or questions about the questions, please let us know. There is a way that you can get those questions to NINR. And if we'll go to the very last slide. So I want to thank, first of all, our FNINR board members for their thoughtful reflections, and all of you for your active participation throughout today's session. We've already seen several important themes emerge, including strengthening translation into real world practice, leveraging AI and data science, and supporting the next generation of the nursing workforce. These insights, along with all the input shared in the Q&A, will be captured and shared with NINR to help inform the development of the next strategic plan. If you, and I'll say this again, if you have additional thoughts or would like to expand your ideas, we encourage you to share them directly with NINR. And so their website is on the slide before you, NINR Strategic Plan at nih.gov. There will also be a formal request for information, an RFI, opening later this year, which will provide opportunity for public input. So again, thank you for your time, your expertise, and your commitment to advancing nursing science. We appreciate your contributions to this very important effort. And this concludes our session. Thanks again.
Thank you.